Nice one. Thanks, Mahir. So hi everyone. Thanks for joining us today in our fireless fireside chat, where we'll be discussing and focusing on how to harness data and make the case for, but also get the most out of a total triage model. As introduction, I'm Chris, Senior Clinical Lead and Clinical Safety Officer working for Accurx, and I also work as a GP. And I'm joined today by Dr. Devin Gray, who doesn't work for Accurx, but is a prominent user of Accurx tools out in the real GP practice world. Dr. Gray, if you'd like to introduce yourself.
Yeah, thank you very much for having me. So I'm a GP at a practice called Putney Mead in Wandsworth in southwest London, and I also have a role supporting digital transformation across the federation. So I help 38 practices in our federation with their digital maturity, digital transformation. A large part of that over the last couple of years has been supporting using tools like Accurx to really help the way that we're working in primary care.
Thanks a lot, Dr. Gray. So today we're going to be talking about total triage, or sort of the modern general practice model, as it's also known. And you can see on your screens now, there's a little kind of pictorial display of like the essence of total triage. But in essence, it is a system that moves away from this model of next caller in line to a GP practice is booked into the next available appointment slot. It's a system in which all patients contacting the practice, and that could be patients online, whether they walk in or whether they call, there's some pertinent information that's collected, or enough information to allow effective triage. And that happens before the booking of any appointment. And that's if an appointment is booked at all. And what this does is it enables a GP surgery to meet patients' needs outside of traditional appointments and prioritise the limited capacity that we know we all have at the moment to support those most in need of care. So a face-to-face appointment is given to someone who really needs a face-to-face appointment, for example. And the time frame and who delivers that appointment can all be decided based on the information you get ahead. So in this fireside chat, we're going to explore how to use data to effectively demonstrate the benefits of total triage for you, for your colleagues, for your wider team, PCN, and how you can plan a transition wisely and maximize the advantages for both you and your patients. There'll be a variety of people in this webinar, so whether you're already using a total triage model or a partial triage model, or you're looking to optimize the value for practice, or in fact, if you're just beginning to explore this approach within your team, we really hope this is going to be valuable for you. And as Mahir said, we're going to leave some time for questions at the end. So let's get started. So Dr. Gray, I know that when making the move to a triage first model, a lot of people who are looking to adopt this could seem like a really daunting first step, and a big change into the way practices work. How can practices who we know are already struggling with limited capacity or staffing make the case for moving to a total triage model?
And I think the first thing actually with this the question is starting with a reframe of it, which is the reminder that total triage frees up capacity. So, you're matching the patient's need with the right professional or place first time, making the most of the MDT or skills in and out of the practice, treating every appointment, whether or not it's this afternoon or in 3 weeks' time, as a precious resource, and recognising that many of the contacts with the practice don't need an appointment at all and can be dealt quicker, better in an alternative way, including self-care. And it's fairer and safer when you're allocating appointments based on need. Now, all of that said, we have a really clear paradox, which is those who are struggling the most have the most to benefit from triage and yet have the least resource to make the change. And that's why I think this is a really important time to be talking about this. Those practices that have the resources and the motivation to do this probably have already. And there are lots of practices out there that maybe recognise some of the benefits, but it feels pretty overwhelming, even considering a major change to the way they're working. So we've got to make it easier for each other by championing good practice and ensuring pitfalls and lessons learned are shared. There's absolutely no one size fits all in general practice, if there's anything that I've learned from this role in the last 2.5 years. But there is no doubt in my mind that prioritising appointments based on need is a universally good idea. And so total triage has the opportunity to be a lifeline to those who feel on the brink of collapsed. And to go back to your question on how to make the case for it, one of the reasons I became quite obsessed with data around triage is because of how predictable and stable it is, but also how reproducible. So one of the purposes of today is to tell you which data can be helpful, but also to really encourage you to share data locally, regionally, nationally, if you want to, through the community groups that Mahir has already explained. And although every practice is of course different, many of the patterns that we see are reproducible. So even if you don't have time to collect your own data, you'll make a really good stab of it by basing it on someone else's.
Thanks. It's really great to hear that potentially the practices that might be struggling the most or feel like they have least capacity for implementing a change like this might benefit most. In your experience, what data is most critical to convince practices out there about the validity of the total triage model?
Yeah, and we've used the term data so far, but actually what's important here, what I'm actually obsessed with as a GP and in this role actually is evidence. You know, as much as I like numbers and graphs, we need to ensure that the data that we're looking for is meaningful. And in order to do that, my recommendation is starting with the context that practice is. We need a really clear understanding of what's going on in any individual practice. So this is about having conversations, about being curious and trying to develop a shared understanding of what is currently going well, what do most people agree are the issues, what are the perceived barriers to change and how could they be overcome. And those first 2 points in particular should be informed by as many people as possible, including your patients. One of the commonest pitfalls I see in my work is where we pin all of our hopes and dreams on the product itself in delivering the change that we need. I had a practice locally who downloaded Accurx within a couple of weeks, were asking to take it off. And I met with them to find out what was going on. And the expectation was that just having the online access would somehow deliver all the benefits that they'd heard about more than neighbouring practices. They just created another inbox and it nearly crushed them. So it's a reminder here that the triage tool is just the tool. The real change comes from a team coming together, stopping to think, you know, taking a break to say, how are we actually working at the moment? How does the patient flow or not through the system? And reimagining how it could work better. And we can't overlook this step, and we can't overlook mapping out what your current system is and what you want to keep and what you want to get rid of. Sort of a reminder that in primary care, our main commodity is people and care, and that's, you know, we just need to keep that in the heart of this. So once you've opened up these conversations and you've agreed at least on these points, is something on each of the areas, then the next thing you want to do is back up your thinking with data and consciously use data to challenge your assumptions. There is no single piece of data or metric that's going to give you a complete picture of the truth, but you can, you know, build it up like putting small pieces of a jigsaw puzzle together. And this is important because we tell ourselves stories to make sense of the world. That's what we do as human beings. And quite often the barriers are mental rather than structural. Just to bring this to life, an example, I'm on call on a Monday evening. So I'm usually triaging, and we work in a hub system at Putney Meads. There's up to 7 people in a room, combination of pharmacists, GPs, GP assistants. And when we're having a really bad day, when we first moved to this model, I'd often hear stories being told about why it was bad. Be like, oh, it's half term next week. I think all the patients are trying to get their requests in before they go on holiday. We tell these sort of explanations, and because I'm the fun police, I get up the Accurx dashboard and, you know, mid conversation and have it up there and say we have had the exact same number of requests today as we did last Monday and the Monday before, within 1 or 2%. We're having a bad day because 2 GPs called on sick and now our AMP is on holiday. So it's really important that we use data to make sure that when we're trying to make explanations for the way that things are happening, that it's based on the right things. And it's very common for us to blame demand when capacity is actually the issue. So in South West London, we have access to a business analytics tool called Apex, which we got through the PCART funding. Other tools are available, but if you don't have access to some kind of demand and capacity planning tool, you need to speak to your PCN, Federation, or ICB to make sure you have access to this kind of data, because what we need to do is get objective about some of these things, just to back up what we believe is going on. And the first thing is to try and get objective about your capacity. So I'm sure you know how many appointments you're offering per 1,000 patients per week, but how often are your patients coming back? Are you looking at the numbers in the context of how you're working? Are you giving a telephone appointment to triage the issue and then booking them in for a face-to-face? Is the patient booked into an appointment with the GP and then the GP is booking them in for the physio for an MSK opinion? What's your DNA rate? How often are your slots blocked for things like supervision, meetings, training, tutorials, admin, private work? What impact is that having on your capacity? Are those all happening on a Monday, which is when we all get 30% of our demand for the week? That number's pretty universal. What's your continuity like? Do you have complex patients being bounced between clinicians taking up additional appointments? This is a really important baselining exercise, because you need to identify where the wins are going to be in your practice, and you'll find yourself ironing out all sorts of other problems on the way. As soon as you take the time to start looking at the detail, again, as an example, when we first moved to a triage model, we saw that we got 30% of our demand on a Monday. Our practice meeting was on a Monday. The partners meeting was a Monday. All of our tutorials were on a Monday. And all that was happening was that demand was being pushed into the week. And then the backstop of Friday meant that Friday was a horrendous day for everyone working in that practice. And just by redistributing how we were using our non-clinical time, we were able to absorb much more of that demand on the Monday, so that it matched more neatly what the demand curve was, how we were putting on our appointments. But those are the kinds of things that is really important to look about. In the middle column there, I've sort of talked about availability, and in my mind, availability is more about how your capacity translates into access for patients. How long are your patients waiting to be seen for routine care, for urgent care? And if you haven't heard of this concept of the average third next available appointment, it's a really helpful proxy for essentially your average next available appointment. But the reason why it's third is because if you look at the first or second, it generally skews the data because of last minute cancellations. So the third next available appointment is sort of an accepted proxy for just when you can next book into an appointment. And I'll show you some data a bit later on about how that has changed at Putney Mead on moving to a total triage model. And then finally, of course, you need to get a clear picture of demand. And that's going to look really different for different practices. But if you're already using a triage system, then that gives you part of the picture. But what about your telephony data? If you don't have a cloud-based system, then that's going to be much harder to interpret. But the vast majority of us are now on a digital phone solution. So what's your abandoned call rate? Again, that needs interpreting, because if in your call queue, you're signposting patients to your online form, you might have quite a high abandoned call rate, and that's great because you're getting people out of the phone line who don't need to be in it. But is your abandoned call rate because they've been waiting for 20 minutes and given up? Are your patients being turned away by reception or signposted to out of hours services when you're open? Do you even know if and when that's happening? And all of this gives you a sense of what your unmet need is. And the reason why you want to have an idea of your unmet need is because you're going to see it when you move to a total triage model. And so it will help you with your planning. But this is more than offset by the benefits. And we can also, to some extent, control it, which we can come on to later.
Thanks, Dr. Gray. It's so interesting to hear about sort of those fluctuant elements of demand, but also capacity within a practice, and the nuances of what your data is actually telling you, and how you can interpret that. And I guess this idea of, that you sort of places this is demand, but also when you unlock it further, is this further unmet need or unmet patient need. Lots of practice, I think, worry that there's this sort of very strong correlation between improving access and then also being swamped by demand. how can practices help to quantify that or be reassured that there won't be an explosion of demand once they migrate across?
I mean, I think that's the single biggest concern for practices when considering a change like this. And I get why we worry about it. We are already so incredibly stretched that even the idea of being told that your demand might increase by 5%, for lots of practice, that will feel like 5% that is more than any of us can handle. So I think an important point to start with is to lay to rest the myth that improving access somehow generates demand. There is a huge amount of evidence which proves it doesn't. And I'm going to show you a graph. I've got the next one here. Okay, so this is from the Accurx dashboard. And this is practices in Wandsworth that are using Accurx, not any other tools, over the last 2 years. And that light grey exponential graph represents adoption of Accurx as a tool for triage, either in a partial or a total triage, but that's uptake. And we now have 27 out of the 38 practices are using Accurx, 15 in a total triage model, 12 in more of a partial model. The dark blue graph at the bottom is Putney Mead, the practice where I work. And for 2 years, we used patient triage in more of a partial approach. So you could request an appointment online, but you could also get through on the phone and request an appointment. And what I just want to show you is that demand curve. So 2 years of using the form in the exact same way, and our demand is flat as a pancake. And then what happened just over a year ago, 13 months ago, we moved to a total triage model. And you can see our demand roughly doubled. That doesn't mean that our demand doubled. All that we've done is taken the demand that was existing somewhere else. It was coming through the phone lines, and we funneled it into the Accurx form. So it roughly doubled, but again, you can see just how flat that curve is. And you know, it might sound obvious when I'm saying it, but just understanding the concept that demand is what it is, and you can control how you see it and how you deal with it, is actually a concept that I don't see being brilliantly well understood. Another sort of analogy that I have in my head, I'm quite a visual person, is a balloon. If you squeeze the balloon on one side, it's just going to balloon somewhere else. So when we have having lots of conversations at the moment with practices about how long to have their online form open for, because of the capacity and access improvement payment, which we'll come on to. But limiting the access to that form just diverts the demand in through another route, and it's often a lot less efficient a route. So I think the main thing is about understanding that, and that this flatness of the curve is not unique to Putney Mead. So you will see, when you move to a total triage model, you will see your unmet needs. So how big that jump up in demand will depend on how big your unmet need is. My argument is that the benefits that can be realised from using an approach like this far outweigh that. So the capacity that you will free up will more than account for that difference. I think I've got another, this was just if you want to see a more granular level. That dip is just because of the bank holidays around Christmas. But the variance across the year is really small. And I've done some analysis on our data and another practice in Wandsworth as well. And the biggest variance across the year between the worst week in January and the quietest week in August is no more than 10%. The only times there were an exception to that was, I don't know if you remember, Chris, but 2 Decembers ago, we had the Strep A crisis. And it was the worst month in my career. And we saw demand increase by 18%. And that was a genuine increase in demand. And that was a combination of the demand of patients calling in to say, I would have normally sat on my child's sore throat and not got an opinion on it, but I'm really worried. And also that translated into significant face-to-face demand because we had to see all of these kids and take swabs. And so that was an exception. So external factors can, of course, change it. But when you just look at demand as a whole, It doesn't. So if you know that patients can't even join your phone queue, if they're, you get told that they need to call back the next day, or they're signposted to 111 in hours, or if your duty team, or however you run your on the day capacity, if your clinicians are on their knees, then you do need to know that you're going to see some more of that demand. But if you carefully plan how you're going to ensure it works well, you will free up more capacity than that unmet need, and you will no longer be working in a firefighting reactive way. And at Putney Mead, it has been incredibly rewarding to be prioritizing our limited resources based on need, and we meet our uncapped demand. We've never put a cap on our online form, whilst also completely transforming our capacity and wait times. And I know that's not the only story, across the country of people that are working in this way.
Yeah, thanks. That's again, so interesting to see that kind of change and how that change sustained itself. And yes, I do remember the Strep A winter. In terms of what you mentioned at the end, in terms of like patients and their access, I guess we've spoken a little bit about the practice perspective on demand and managing demand. But we also have to remember the patient perspective in this too. So what role does, I guess, patient and their sentiments and feedback play in the transition to total triage?
It's a good question, and they're essential. They're part of that data gathering at the beginning, so sort of mention them a bit at the beginning, but actually don't forget to go back to them once you've implemented the system, or better still, when you've designed the system, when you're about to implement it, and ensure that their feedback influences your sort of mini PDSA cycles. Just as a very simple example, we looked at our patient feedback closely and continually after we moved to total triage, and we had a comment that came up 3 or 4 times in a row from patients saying, your online form needs to be a single click from your website. And we went back to our website and we realized, because we were trying to put quite a lot of information about the new system, kind of had to click through 3 different bits to get to the actual form. It was a 5-minute fix and it was really quick. It was just the example of we weren't really focusing enough on what it was like from the patient side. There's often a mismatch between what the practice thinks the issues are and what the patients think. The truth is almost certainly somewhere in the middle. But again, really encourage us to use patient data to challenge our assumptions and break out of these narratives, which we get a bit stuck in. The GP patient survey data is useful, and there are drawbacks. I think the numbers are very small and we don't really have control over where they go, but so have a look at that, but also go out and get your own data. It's very quick and easy to set up a quick MS Forms or Google Forms and send it out via email to your practices. Obviously email is free, but I also think there's a role for using, many people on this call will maybe be totally convinced already of total triage, but they're in a PCN and they really want the other practices in the PCN to get on board with this so that they can access different benefits. That might be financial benefits through the improvement, the CAPE funding. It might be through wanting to work as a hub model, whatever it is. So there's an opportunity here to use, and you might not have access to those patients to ask them the questions. So it is useful to go to places like the GP patient survey. And I'm going to show you a snapshot here. So this is a PCN, anonymized. And, there was a meeting where I went in and I was trying to encourage all the practices in the PCN to think about their access and their continuity, and asking the question at the beginning, how is your access? All of them felt their access was fine, but GP patient data suggested there was quite a lot of variance, and even that practice with the 80% positive feedback from patients was a very small practice. Fantastic feedback on continuity and access. Frankly, I was trying to pick their brains on how they did things, but you you need to ask the question. So I asked them what happens if one of the receptionists is off sick, because their system worked really well all through the phone, so they didn't see a role for an online form. Well, when a receptionist was off sick, which wasn't that uncommon, the practice manager was on the phone the whole day. Great for access, great for patient continuity. It's quite a lot of work for a practice manager to do and to not be able to do for a whole day, and thinking about the impact on that practice in terms of keeping on top of emails, accessing funding, or, you know, all the things that are related to that incredibly busy job. Or there's another practice in this PCN who are offering a walk-in service for their patients. So again, access, feedback, brilliant, because if you want an appointment, you just pitch up in the morning and they'll see you. But again, the question was, well, what happens if a patient can't come down to the surgery? What if they're too unwell, or they need a home visit, or they're, you know, on the other side of town and they want an appointment this afternoon? How can you ensure parity of access? So it's sort of using data to make sure you're asking the right questions. And another example here of continuity, and this is patients' experience of continuity. So, you know, there's, in my mind, I think of sort of big C continuity and small c continuity. So big C continuity at Putney Mead is patients on my named list, and they might have me as a named GP because they're on the SMI register, or they're on the safeguarding register or something like that, and can they get in to see me as my named GP? But there's also the type of continuity as someone comes with abdominal pain, and then they're seeing a different GP to follow up the results, and they're seeing another GP 3 weeks later when their symptoms haven't got better. And, you know, this is about challenging the assumptions, using the data to sort of help to unpick where the issues really are. And then this is another aspect of patient feedback, which I'm really keen to emphasize. And I hear this a lot. Our patients don't want to use an online form. And my request here is really, please don't make assumptions about what your patients can and can't do with technology. In some populations, there will be some major barriers, and they're very important to understand and address. But the practice is often swayed, in my experience, by a handful of patients, but they don't go out and seek to understand the needs more broadly. And it's remembering that deprivation is not the only cause of digital exclusion. So we need to be thinking about how those with learning disability or neurodiversity, language barriers, visual impairments, any of those accessibility issues, how do they need to be considered, either the way that you're currently working or the way that you're planning to work? What are the actual barriers in your population? And don't let these challenges stop you from making an effort to improve access. I think one of the most frustrating conversations I have is when we say, we don't think they want to use the form in this way, so we're just not going to make it better for anyone. You know, the key word on access for me is parity. You know, it's about fairness of access. Many are rightly concerned about leaving behind those who don't have access to digital tools, but it's not a reason not to use digital tools. It's just about a job that needs to be done well. And lots of services and charities exist to support access, and make sure you're connected with these and make the most of them. So many of us will have a social prescriber, and they will be already connected to those kind of organisations in the community. Public libraries are brilliant. Age UK have got their own digital inclusion programme. We have a really active Age UK in Wandsworth that do lots of even one-on-one work with residents around upskilling on use of the, you know, the NHS app, email. Good Things Foundation have a data bank and a device bank. Have you seen their deprivation risk index? You can have a sort of immediate snapshot of your digital exclusion risk in your area. You just Google Good Things Foundation and digital exclusion. Health Watch is really well connected to its members. And what community groups do you have in your area that represent certain cultures or languages that can help you to make sure that when you're designing your system, you're including that? So it's just really about knowing where the gaps are and making sure you're addressing them. One other thing, actually, while I'm thinking about it, is your telephony provider. So we have started a system where when a patient tells us that they don't have a smartphone or useful internet or have any other reason why they can't use the online form, what a lot of the feedback suggests is that they're fed up of fighting with reception every time they call in, that they're told to use a form and they have to explain every time that they can't use a form. So what we've done is we put a code on these patients' records, and then we've added that into our call flow, and these patients have a little flag that comes up so that when the receptionists pick up the phone, it immediately flags that they can't use the form. And therefore, the first conversation they're having is, I know you can't use the form, so why don't you tell me what the issue is and I'll pass it on to the GP, rather than having to fight the, did you know we have an online form piece? And all of this feeds into better patient experience of access. And then when they come in through the door and sit in front of you as a clinician, you're not having the first 3 or 4 minutes of the consultation having an argument about how poor their access was and, you know, didn't they know they don't have to use the form? You know, it makes things better for everyone. And another metric, of course, is the NHS uptake data, which is publicly available. But just remember that tells you what your practice population currently is, you know, where they're currently at with access to healthcare through their phone or their computer, but it doesn't tell you about the potential. So, you know, it's really, really useful because it can tell you, well, there's no point in us pushing loads of messages about the NHS app functionality if we haven't actually got the app on most of our patients' phones yet. So, you know, we need to address that first before we then show them how to use things. And my final thing on this is don't assume all access is via a smartphone. We have lots of patients in their 70s, 80s, 90s at Putney Mead who are very comfortable with the internet, with email via computer, and something like a third of our online requests are made on a computer rather than a smartphone. In October, I sent an email out to 2,000 patients who had had an appointment in the preceding fortnight to get their feedback on their experience of using the form and subsequent appointment, which took less than 10 minutes to do, to design the form and send it out through Accurx batch email. And the biggest age group who responded were in the 60 to 80 age range. And the feedback across the whole questionnaire was 80% positive. So it's really just making sure that I think we talk about patient engagement, but we're not actually very good at doing it.
It's quite insightful to hear the ways that you've supported access for particularly patients that can't use an online form. And I guess the online access is actually designed in the first instance to support access in general rather than replace or be just a blanket replacement. So yeah, it's really interesting to hear those kind of like on the ground ways of working and insights there. You mentioned in your last sort of response that you referenced some smaller practices and different ways of working, and we've no doubt got a variety of practices and setups on the call today, and potentially perhaps a smaller practice with that limited resource. You speak about a practice manager taking over from someone who's sick. The smaller practice might say, well, it's all well and good for a large practice, but how could we possibly make a move to total triage? And I guess what advice would you give to them?
I appreciate that challenge because, you know, when you work in a large practice, and Putney Mead's got just shy of 26,000 patients, we have dozens of clinical staff, board MDT, PAs, AMP, you know, physios, the lot. And I know from experience at smaller practices, smaller estates, we don't recognise that model of primary care. It doesn't feel like something they can learn from. There is also no doubt in my mind that the early adopters on the whole were these bigger practices who could benefit from economies of scale to make this work sooner. But we are increasingly seeing smaller practices very successfully move to a triage model and realise the benefits. And I think this comes down to the power of peer learning. And I know Accurx have really got on board with this because you have your peer ambassador programme, and, you know, we're all realising how beneficial this is. We're quite a sceptical bunch in primary care, and I'm okay with that. We want to learn from those who feel like they represent us. So I was recently at a PCN meeting talking about triage, and at the end, I asked for some feedback. and was told that there was one slide that I had on there that was the most powerful them in terms of shifting their mindset from totally disinterested to maybe a bit interested about triage. I think I've got it coming up actually here. So I mean, I put the name, they were local practices, and I got permission from the 2 local practices to quote them. These were 2 practices locally, much smaller than many of the others that had previously started using it. And particularly the one on the left with the 4,500 practices was in the area of patients in the area of high deprivation. And these other small practices were like, that's really interesting. Oh, I'm dying to know how it's going for them. Why did they choose to do that? So my point here is that we need to be learning from each other. We need to be modeling it for each other, and we need to be generous with our time. If you have started using an approach and it's going well, you know, please offer to your neighbouring practices, or maybe it's not that physically close. Maybe you're all in one ICB, but not necessarily in the same place. Allow people to come in and ask you questions and see how it's working. I think in my experience, that's been the most powerful of all. And if you're a practice who hasn't yet done this, please go out and ask. And if you're not sure who's using what, you know, reach out to your federation, or to, if you've got a clinical lead in the digital space, to say who is most like us that I could go and learn from, and then take all the best bits from them, which is what we did. I think we went as far as Oxford to see a practice that was kind of similar in setup to us, to see. And when I went in for the first time, there were some things they were doing, I was like, it doesn't make sense at all. And you know, it's quite helpful to have people come in and challenge you, and they're like, oh, I don't know why we do that, it's just how we've always done it. So it always makes you, like when you're a clinician, have someone sitting in and watching you consult, you suddenly find that you're consulting a bit differently when someone's coming in and having a look. No, there's not another slide on that. So, you know, it isn't just about list side or practices in a physically small footprint. This is also about recognizing that, you know, we do all have different challenges, different setups, different populations, and there's no one way of doing it. So even within one PCN, I've got one practice, they use Accurx just for the on-the-day demand, and they don't use it for routine. And the other practice does the polar opposite. They just use it for routine, and they deal with their on-calls not in another way. I'm hoping over time that I can continue to support them to look at other ways of doing it, because I think there are probably more efficient ways of doing it. But we also just need to allow each other to do what works. And it might be that it's kind of stepwise. So we did 2.5 years of partial triage before we made the move to total triage. Several practices have done that, and that's worked well. Others have just gone in full hog, and you know, that's fine. But the main takeaway for me is learn from each other, particularly the smaller practices.
Interesting. You mentioned a bit about sort of going to partial triage, which I'll pick up on in a second, but I did see the next slide flash up, which had about capacity and access payments. And we know that beyond the sort of managing demand and making the best use of your capacity as a practice is of utmost importance. But then there's also external motivators towards a model like this. And one example is the capacity and access, or CAPE payments. Like, how can practices quantify financial benefits of adopting total triage, or lean into these methods of working and linking them to the funding streams?
Yeah, I mean, in many ways, I'll show that slide in a moment about the, you know, it's easier to talk about the capacity and access improvement payments because it's, you know, you either get the money or you don't, and this is the amount that you get based on your list size. The benefits otherwise, or the financial benefits of moving to total triage, can be difficult to quantify. And I know you've had external speakers come and do webinars on this. So, you know, if that's something you're specifically interested in, then definitely catch up on recordings of previous webinars on that. But if you go back to the very first exercise where you're looking at numbers, you can put some numbers on where you think work is being duplicated, where capacity is being wasted, where appointments are being given unnecessarily, and you can estimate how much capacity you will save. And then you can look, right, how can I then redeploy that? What does that mean? Does that mean I'm employing one fewer locum each week, or whatever it is, you can then translate that in whatever is meaning for you financially. That's quite a big task. So I also recommend, again, asking other practices that have already working this way, of a similar size, and say, well, actually, how many appointments, you're working in a total triage model, if we do that, how many appointments do you put on that are on the day? How many do you put on that are a routine? We're all going to be doing it a bit differently, but because in my experience, the data is so sort of stable and reproducible, you can definitely learn from others without having to map it all out. You'll say, you know, I've spoken to several practices who have freed up a third of their capacity using a total triage model, and we found that at Putney Mead, even moving from a partial model. I haven't yet found a single practice in Wandsworth who would go back how they were working before, which in itself is quite a powerful statement. So it's a much more muddy answer of, you know, what are the financial benefits from the capacity that you're improving, especially because it's not just financial benefits. If you've got happier staff and happier payments, that might be more than enough for you. But the reason why I wanted to share something about Kate is because the end of the financial year is now only a quarter of the year away. I've had lots of practices contacting me in the last few weeks, sort of saying, well, hang on a minute, we're using total triage, our form is open for core hours, we're looking at applying for this money, and we can't get it because the other two practices we're in a PCN with, okay, they are using triage, but they're not yet using a total triage model, or they're closing the form for 3 hours at lunchtime, or it closes at 3 o'clock. So this has suddenly become much more kind of at the front of people's minds. And it's really just a reminder here about what the money is that you're looking at. So most people will know that the sort of 70% of the funding is that unconditional bit, and then there's a 30% which is contingent on the PCN sort of meeting some criteria in these 3 areas, and at each 10%. There's a digital telephony one, but the other two are essentially around triage, and it's around parity of access. There's something around continuity, and there is something about the form being on for core hours. And if all 3 of those are met and the funding granted, I'm just giving you an example of a PCN with around 40,000 patients. This is what it looks like. This PCN has got quite big size variation. So that's the amount, you know, which is not insignificant. So it is worth applying for this money if you can. And then a reminder, I'm sure you know about this, but about the transition cover and transformation support with practices can apply for to cover the costs of moving to a new model. And that's not sort of licensing costs or anything. That's more about the time to plan, maybe backfill, maybe clearing the decks before you launch. I mean, I think I might come on to talk about the hours the forms are open, and the impact that has on demand. But I know that this is going to be a lot at the forefront of a lot of practices' minds at the moment, and how do they make sure that they're making the most of that funding? And for some practices, they will not be able to access that because the sort of digital maturity across their PCN just won't be there by the end of the year. The only final thing that I would say is this needs to just be in place at the point that you apply. So, you know, if you've been thinking about it for a while, you can put these things in place by the end of February and request it. And as long as that kind of goes through by the end of the financial year and you keep that in place, then you can still access the funding. It will come through as a lump sum probably in April.
Okay, thanks, Dr. Gray. We've spoken a bit about sort of finances and also the run up and assessing readiness to migrate to a total triage model. But what are sort of the key metrics that you should monitor once you have adopted the total triage model, and how can this data be used to sort of improve the model going forwards?
I'm going to rattle through this because I can see that we're running quite short on time. So in terms of what you're then looking to monitor, I would link that really closely right to the very first slide when we said, well, what have we agreed are the problems? You know, what do we want to get out of it? That's what's going to be most meaningfully measure what you've said was important right at the beginning. One thing I just want to flag is just my experience of being mindful of your blind spots. So you don't know, if you're just looking at what you think you need to know, you might miss the bits that you didn't consider. So one of those is around making sure you're not over focusing on your on-the-day demand. We can get a bit obsessed with that when we move to a triage model, but you need to really make sure that we're still allowing capacity for the long-term condition prevention work, because that's where some of the funding is. More importantly, that's where good patient care happens and good preventative work, which means that your on-the-day demand lessens, you know, however many years down the line. Be careful about continuity. I think there's a real opportunity here to improve continuity. There's that lovely little box if you're using Accurx that says who's the clinician you'd ideally like to see. If someone puts in a name there, then try and honour it. Give them the choice if that clinician isn't available, but you know, do what you can. We move slots around to try and accommodate a continuity where we can. And you know, the only other piece on the patient feedback bit is around the kind of human touch and actually helping people to understand that they are still, the triage process is being done by a clinician. Can you make sure when you are triaging, if you're then not offering an appointment, how can you be really explicit with your empathy and kind of make sure that you're delivering that human touch if you can through the technology, because it really makes a difference. And I know that SMS fragments are a massive pressure for us, but I think it's a false economy to not start your message with, I'm really sorry to hear about your miscarriage. Here is your fit note. Here are some signposted, some resources, and please let us know if we can support you with any way. And, you know, that's sometimes where we're really pressurized with those fragments. We miss that out, and that human connection is lost.
Okay, thanks so much. Again, yeah, the time is rattling on. I guess, do you have any final things you would like to mention about sort of balancing demand capacity effectively when managing triage requests and appointment availability?
There's one thing this is what I wanted to show you what our graphs look like at Putney Mead. So this was the third next available appointment, and I only looked at GP, PA and AMP appointments because that's what we were kind of using as a metric for a kind of clinical capacity. But it was just to show how that dropped from 28 and has stayed down. Our reattendance rate has come down and our continuity has gone up. So it's just really a visual of some of the benefits that you can see. This is not an official table, but this is you know, just my observations. But it's just really to flag that the hours that you advertise your form is available and the response time that you advertise the form will have a direct impact on what demand you receive through the form. And this again is not generating demand. This is demand that exists, and you're choosing how much of it you want to flow through your form and how much of it you want to squeeze out into other areas. And if you look at the bottom 3 rows there, the only difference, and this is based on Southwest London data, the only difference between those bottom 4 rows is the advertised response time to the form. And you can see how it drops off. Patients won't use it for obviously anything acute if it says that they're not going to get a response within 3 days. So I find this really helpful. And also it helps me to see if someone's getting a lot of requests that fall outside of this range, something funny is going on. And I often look at the dashboard first and then we'll contact practice and say something doesn't add up here. Can I come in and try and work out what's going on? So that's the only other the thing that I wanted to flag before we move to questions.
Yeah, it's so interesting to see how such small changes in the way we communicate, but also in the timeframes we give, can make such an impact on like patient perception and then actually how likely they are to reach out. Thanks so much for taking the time to go through a lot of those data insights. We do have some questions. Let me bring up the Q&A section here, and we can go through a couple. Any that we're not able to answer here, we could probably take offline and give some answers later. Let's have a look here from the top though. Um, I can't. My scroller is completely broken. There we go.
There's one here that just talks about call flow from Melanie Crabtree. I would encourage reaching out to your telephony provider. So we're using Surgery Connect, and they have something called the Academy, and you can go online and have a look, or you can just email them through their support, and they'll send you details of what they call personalized call flow. But it's you can configure these digital telephone tools in any way that you want, and there's so much opportunity there. I heard last night of a practice who takes patients with a dementia code, and they have far fewer options, so which they find confusing. So it's, you know, they don't have to go through all the press 1, press 2, press 3. It just gets them straight through to someone. So there's brilliant work that's being done with these digital tools.
I think there's another couple of questions about what tools to use to gather data on unmet demand, and there's another one about getting some links to what Dr. Gray was referring to. I imagine that's to these tools that you use.
Yeah, I mean, again, we use Apex in Southwest London. I think any demand and capacity or sort of business intelligence tool would have very similar metrics on there. But I mean, I also think it, you know, you might one practice's DNA rate might be really quite low and not a big issue. Another practice might have a DNA rate of 15%. So, you know, what to focus on is very, very practice specific.
And someone asked about, is it a code for those who can't use the triage form, or an alert on the patient's records?
So so I found a SNOMED code called digital exclusion. And that's what I use to identify it's not easy to identify the patients. We're doing it very organically at the moment, where if we come across a patient who says, I don't want to use the form, we add the code. And I'm sure we can also run a search for those who don't have a mobile number, but I don't want to make assumptions. And then in the call flow, you don't have to even put that code on there. You can write whatever you want. So you can write does not have access to the form. And then when they call in, that pops up as a little alert. It will look different with different telephony providers, but they're all doing very similar things in that space.
Great, thank you. There's someone else who asked about the code to identify the patients.
I'm going to read this one from David Brown. I'm concerned about dealing with Monday morning. We have an old-fashioned GP model. Yep, no PA, NPs, ACPs. So if a GP is purely going through the triage, it takes them out seeing patients. Yes, I'm really glad you asked that question, David, because that's one of the commonest questions that come up. That there are options of doing it. So it's easy at a big practice to say, oh yeah, we'll take 2 GPs out to triage. If you're in a smaller practice, it might be that you have a couple of chunks of time. So it might be the first hour of the morning and the first hour of the afternoon that you're triaging. You might need to look at the numbers again. The screen that I'm sharing at the moment, you can work out what your number of requests per 1,000 patients per 7 days is going to be just by plugging those numbers into the calculator. The other thing you can do is to outsource the triage. So you can, get, for example, I know practices that have a paramedic who triages for them. Where that works best is where the paramedic is physically in the practice and they triage and also bring patients in to see really quickly. And in some places that works really well. So you can outsource it. You can split your session out. You can get in ARS staff. So it's going to be unique how you plan it, but you won't need someone triaging all day if you have a much smaller list size. I've also just seen there Nicola Davis. I'm just going to pull to the next slide, Nicola, to answer your question. Fleming Jensen shared this with me, so I'm crediting him with this, but it's very hard to get a really clear picture on what the outcomes is without looking at manually. So my recommendation, if you've already moved to a total triage model, is do a snapshot audit. So for 24 hours, just really capture what you're doing and where they're going. But where others have done it, this is pretty representative of what happens at Putney Mead as well. It's roughly 50% get triaged to a routine, 10% to urgent, 30% are closed without requiring an appointment at all, and 10% signposted out of the practice. So, you know, that's where your kind of 35% freeing up capacity comes from, as well as all the other things like addressing how you're working generally, avoiding duplication of work, avoiding reattendance rates, making sure that continuity is supported.
That's been really helpful, Dr. Gray and Dr. Sartori. Thank you so much for providing all of that insight. If you just head over to the next slide, Dr. Gray, be a QR code for our community where we will post. I know that there's some outstanding questions in the Q&A. We can post a little follow-up update in there with additional resources as well as the recording for this webinar.